Next we have tips and tricks of managing intraoperative surprises, and it is presented by Dr. Merine Paul. Dr. Merine is a well-known cataract and phaco surgeon since 1998. She is currently medical director of Trinity Eye Hospital, Thrissur. She did her MBBS and MS from MGIMS Sevagram, Vardha. She did her DNB a year later. She has got the first phaco in Kerala from AIOS in cataract and phaco surgery. Over to you, madam.
Thank you, Dr. Ambika, for having me here, and a very, very good afternoon to all of you. Thank you all for being here. So when Dr. Ambika told me that, do a presentation, and so she said, ma'am, will you talk on intraoperative surprises? And that is what I prepared. And I think it has worked out well, because I feel that there is a difference. Okay, I'm not visible here, right? Okay. I feel that there is a definite but subtle difference between what are surprises that happen and complications like what Ambika showed us just now, which you are anticipating preoperatively. When something is there preoperatively, you know that, in your mind that like, okay, these are the stuff that can go wrong. These are the complications which are likely to happen, and you prepare for them mentally and with the hardware that you have in your theater. Now, another thing that I'm going to specify here is that my talk would not be for people who have, access to everything at all the times. So we know that, like, when most of the talks are done from major institutions, major hospitals, where you have the best equipment and you have the best, supporting equipment as well. But many of us in smaller institutes, in smaller hospitals, especially single owner-owned hospitals, do struggle at times with things, which are not often, used, and so you may not have it in time. So that is something which I'm going to talk about. So like I said, so what are the common problems that you would face in a routinely in an intraoperative scenario? So we know that there is a hypermature cataract. It is possible that there may be a Argentinian flag sign. So you are mentally prepared for it. But there are times when a regular looking, innocent looking cataract suddenly misbehaves and the rexus starts going to the periphery. Happens, right? So that is a surprise. You need to have a strategy in mind to tackle that. Similarly, you see a patient with a with a pseudo-exfoliation or a previous history of trauma or one of those syndromes like Marfan's or any of those syndromes. You know in your mind, yes, there's a possibility there is a zonulopathy. Now, the interesting thing about zonulopathy is that a gross subluxation or a dislocation can be easily diagnosed preoperatively. But zonular weakness is actually an intraoperative diagnosis. From the studies available now, it is shown that almost 95% of intraoperative zonular weakness, I'm not talking about subluxation, I'm not talking about zonular dialysis, but zonular weakness is an intraoperative diagnosis. And many, many times we see it we can only diagnose it on the table. Similarly, a patient who is on prostate meds, there can be IFIS, that. But imagine a woman in her, say, 40s who is on some antihypertensives, you have not paid attention to it, can still develop IFIS. Why? Because there are some antihypertensives like labetalol, etc., which, because we don't keep in touch with a lot of what physicians are, prescribing. They can develop IFIS, and it just comes as a bolt from the blue. You're not expecting it. Intraoperative meiosis, again, senile meiosis patients and all, you are like prepared. Yes, it can happen. But there are those cases where, for no reason at all, the pupil goes down. PCR, I think, is always a surprise, except for probably a posterior polar cataract. Every time it is a shock. Similarly, IOL damage can't be predicted. So I will take you through a couple of cases Yeah. So before I start this video, let me give you a caveat there. This was a case which I did when during the COVID times. So this was a small charitable hospital. There was lot of supply chain issues, and there was a long list, and this seemed to be a very innocuous case, and we started off, it was the last case in the list, and we already had about 3 or 4 cases requiring iris hooks. And when we started off, when we started off, everything looked pretty okay. And I started with the, you can see when I started the rexis, everything looks okay. There's slight meiosis, but nothing that is not manageable. After the hydrodissection, the pupil seems to come down a little bit. But when I'm doing the rotation, the pupil has come down further. And at that point, yes, so when I went in with the phaco probe, the pupil literally like came down it became a very small pupil, and I stopped surgery and asked for iris hooks. And at that point, they say, ma'am, they pretended to search and finally said that, ma'am, there are no more iris hooks left for the day. So what now? In such situations, your friend is the viscoelastic. So you repeatedly reform the chamber, stay right in the center, always master your chops, because even if you do your divide and conquer, in these situations only chop will work. So stay right in the center, try not to touch the pupillary margins. There is iris prolapse. In those situations, push it back with cohesive viscoelastics so that you get some space in the anterior chamber. Divide it into very, very tiny pieces, always with the chop, and then eat it up individually. So frankly, with a lot of luck as well, I was able to complete that case or manage the nucleus without much trouble. And once the nuclear bits were out, the next step also is quite challenging, because you can't see the extent of how much cortex is there. So it was practically done as a blind procedure using the second instrument to pull back the pupillary margins, removed the cortex, and finally injected the IOL. Once the IOL is in place, we have to retract the iris in 360 degrees to make sure that there is no, because you have divided the nucleus into very small pieces. Those small pieces can hide very easily under the iris. So do make sure that there are no nuclear fragments. Cortex is more forgiving. If you leave behind even a small nuclear fragment, this will lead to intractable uveitis. You will have no idea why this uveitis is happening. You'll keep on, wondering. After about, 3-4 episodes of uveitis, you'll find that one piece of nucleus fragment coming into the anterior chamber has happened. So these are things which you need to, so the tip here is that if you do not have, access to either a iris hook or a B-hex, in these situations, do keep your probe central, use plenty of viscoelastics, and always check the periphery at the end of the surgery to see that you have not left behind anything. So that was about that case. Our next case, this is that case just finishing up. Next case was a case of rexis. This was a case, I just started the rexis and I realized that there's a lot of, you can see those folds on the anterior capsular surface. This is because there is zonular weakness. This was an absolutely, not at all expected. And then you changed from the needle to the utrata forceps, again pressurizing the chamber at all points. But always support the lens with a second instrument so that you are giving sufficient counter traction when you are doing the rexis. But every time you pull it, you will find that there are folds forming on the anterior capsular surface. Now, in spite of all this, the rexis has gone now to the periphery, and here I have used the Little's procedure to pull that little last fragment into the anterior, into the center and completed that. So tip here is that stabilize the capsule with a second instrument, and if there is rhexis runaway, use a second Little's procedure. And this was a case where everything looked okay, but after the nucleus management, the bag has crawled in on itself, and there is a zonular dehiscence. So repressurize the chamber with viscoelastic, and at these points there is no other go but to use a CTR to stabilize the capsular bag, and then we can do the further this thing. Now, important thing in this is that because there is cortex left behind in these situations, you may have to do a tornado type of or a hurricane technique for removing the cortex, and always make sure that the open part of the lens, once almost done, of the ring is away, facing away from the area of dialysis. And the final video is that of iris, haptic braking. You can see that the entire haptic is in the cartridge. In this situation, there is no other go. I try, if the length of that haptic is slightly, broken haptic is slightly longer and your rhexis is smaller, you can attempt an optic capture, but not really recommended. But in this case, I just explanted it because there was no way this lens was going to center. So thank you very much for your kind attention. I hope that was useful.
Thank you, madam. Thank you. Yeah, so again, sticking back to that same thing, change your strategy when you encounter surprises.